Yes, let's go. Let's begin.
Okay, we're so delighted today to have Dr. Colleen Varcoe with us. Colleen is a professor at the University of British Columbia, the School of Nursing. Colleen works to decrease interpersonal and structural inequities and violence, including racism and poverty. So welcome, Colleen, and please feel free to introduce yourself in any other way you like to our attendees. Hi.
Thank you, Ostiam. Thank you, Nancy. And are you seeing my beautiful screen properly, Nancy? Yeah, you are. Okay. So thank you, everybody, for having me here. As you can see, I'm coming to you from the Stolo, unceded territory of the Scowlitz people. So you're looking at exactly where I am today, at the confluence of the Fraser and the Harrison Rivers, which is traditional territory of the Stolo, specifically the Scowlitz people. So first of all, Haichka Osiam to Elder Jerry for that lovely message of friendship, particularly in the face of such tragic unveilings. It's just it's heartrending. And thank you to Leslie and the whole team for inviting Annette and I to be here today. So I'm hoping I can figure out how to advance my slides, which I'm not exactly sure how to do. I did. So I wanted to also say I am my biological father is Cherokee from Tulsa, Oklahoma, but I was raised almost entirely on Treaty 1 in Manitoba. And the importance of that is that because inside, even if I wear white privilege, no one can tell me, having grown up on the north end of Winnipeg, no one can tell me that racism isn't a daily grind. So I just thought I'd share that with you. So I'm speaking on behalf of Annette Brown and myself. Annette will be joining us at about 10 o'clock, but she had to be in another meeting. So her apologies for not being able to speak to you yet, but she'll talk to you a little bit later. And I wanted to say that Annette and I are just really honored to be here, but we wanted to kind of get out of the way because we think the Indigenous leadership are the people that we need to be hearing from. But what we're trying to bring to you today is sort of some thoughts from our program of research. So we've been working over the last probably 20 years on racism and trying to address racism within healthcare. So we've done all this series of studies looking at not just how racism operates and its impact and so on, but how do we eradicate it? And we started by studying how particularly Indigenous focused primary care settings really deliver good care in a really good way. And how could we take that into the rest of the healthcare system? So we've been doing that, and we've tried to work in partnership with healthcare settings in primary care and now in emergency settings to try to improve how care is delivered. And particularly, how do you promote cultural safety? How do you tackle racism? And how do you promote what we call trauma and violence informed care? So Annette and I are bringing to you that and our experiences in our kind of our service to the communities. Annette has not only done this research, but she's done things such as be on the Brian Sinclair working group with Dr. LaValle. She was just recently an expert witness in the Joyce Echaquan inquiry, which ends tomorrow. You know, we've also together led in our School of Nursing the Anti-Racism Task Force, and you know, we've done various things like that. I was on a expert witness. I was an expert witness on in the death of Ina Matapwit, who was a woman who died in Northern Ontario in a small North Caribou Lake First Nation. And these are some of the things that have given us insight. I'm sorry to tell you, though, that we're not really going to say anything new. Had a look at the chat and who's here, and many of you know this much better than I. So, but we thought we would just share a few thoughts that are very clear to us from our years and years of observing and measuring and studying and trying to make change, big cultural change in healthcare settings, and then just make a few points that hopefully might be of some use. And so we wanted to say, well, what is the status quo in healthcare that we're trying to change? And you know, it's the daily grind. It's every Indigenous person, and I think Elder Jerry said, cut by racism when they engage with the healthcare system. And so it's about those interpersonal interactions, but it's also about the structures. It's about how things look. It's about how people are treated. So the harms that are done, I think all of us already know. Everything from little microaggressions on a daily basis to very tragic health outcomes. And I just wanted to share that when I was, as we call it, collecting data in one of the emergency units that we work with, I had a very disturbing experience, and that was that I came on to interview patients and saw a man sitting in a wheelchair, and you know, he was visibly an Indigenous man, and it just struck me that he was in a wheelchair, and because we've been working, and Annette had got the permission of Mr. Brian Sinclair's family to use his photo as kind of a touch point for what we were trying to do in emergency units. He just struck me, and so I kind of noticed him. And yet I went around and I was doing my interviewing, and this was at 1 o'clock. I came on shift, and by about 5 o'clock, I asked one of the research assistants, "Have we interviewed that man?" No, we hadn't interviewed him. And I said, "Well, do you want to see if he would be interested?" So he was interested. We interviewed him, and then we tried to get his acuity number from the triage staff, and they said, "Oh no, he's gone." And we said, "No, he's not gone. He's right there." No, he's been discharged. And we go, oh, he's been discharged. Okay, so we went and did the other half of his interview about his experience, and then we circled back to still try to see if we could find that acuity number. And they had discovered that no, of course he hadn't been discharged. They just put his admission form in a garbage can or something, I don't know, but he was not going to ever be seen. So this man, I don't know what would have happened, because that was 4 or 5 hours later. I don't know what would have happened if he ever would have been discovered, or if he would have sat there forever, because he was a very kind, gentle man. And one could say, well, how is that about racism, Colleen? Well, it's about all the people walking by and not noticing other people. It's about no system in place to make sure that nobody falls through the cracks. I think it's about a system that depends on people to quote unquote speak up. And yet, if certain people speak up, they can get tossed by security. So I think it's about our system. It's not just about, as I'll argue with you, bad apples. So I think it's also about a system that positions healthcare providers as though they're in opposition to the patients, the people they serve. And Annette and I are working with Kilala Lalem, which is, we've both been on the board of it in the Downtown East Side, an Indigenous-led primary healthcare clinic, and we were interviewing the staff a few weeks ago, and we said, well, what's the difference between how you provide care and how care is provided in other parts of the healthcare system? And one of the staff said, we adore our members. That's the difference. We adore our members. So that's where we want to get to, is where we all adore the people that we serve and we come in friendship. So we thought we'd just say a little bit about what we see as the dynamics that keep it all in place. And many of you know this, as I've said, better than I. But one of the things is that I think, particularly in the sort of the white settler society, violence is understood as, Zizek calls it, as the spectacular eruptions of violence performed by a clearly identified agent. So it's by an individual, somebody that's known. And that's how we see violence. And I think we have to unseat that if we're going to really eradicate racism. And the other thing is we constantly default to, in concert with that idea, we default to identifying the bad apple, as if racism is about individual bad apples. And I think that understanding isn't serving us well. So, the problem with this is that, when we look at the spectacular eruptions of racism, then they can get read as though they're one-offs. And that, I believe, is a strategy to contain responsibility. That is to say, to absolve other people of taking responsibility for our systems and how they operate and for white privilege. So that's what I think we would argue needs to be undone. Another thing is this idea of this constant pull towards culturalism. So, we've been using the concept of cultural safety, working with Leslie and Cheryl and others, forwarding Sanyas as an approach, and it's explicitly anti-racist, but we've been using the term cultural safety. And what we found is that in our work in healthcare, people want the cultural part, but not the safety part, or they want the culture, but not to undo the systems that maintain racism. So, sometimes in healthcare settings, people are happy to find a place where families can smudge, for example, but they're not necessarily ready to tackle the systems of racism that are pervasive throughout the entire place. So, what we found is that our work is acceptable to some extent when we lead with the cultural angle of things. I lead interventions for women who've experienced violence, and even very mainstream settings are really drawn to the idea that we're there's elder-led circles and that there's culture infused, but not necessarily dismantling the sort of the processes, the policies, and the systems that need changing. So we worry that a lot of these strategies just give the appearance that something is being done, but not really tackling and I think Barry's going to talk about this quite a bit more, but really challenging the missing part of the story, which is tackling and dismantling white privilege. Again, Elder Jerry said that people only fight for two reasons: ideology and resources. And so what are the ideologies and the discourses that keep it in place? And we hear this over and over and over again. We treat everybody the same. We're completely colorblind. And my response to those kinds of statements is horror. I say, you treat everybody the same? That's awful. Why would you do that? That's not what's needed. So these are the kinds of things that I think are used as, again, as defenses to maintain privilege, which, you know, I argue is a missing ingredient that we need to be talking about. So we have Annette and I just have 6 points that we want to make. Again, I'm going to say that most of you probably know this better than I do, but we're hoping that together this coalition will get formed. And I have to say, Leslie, this was a high speed, get a conference together and invite hundreds and hundreds of people and have 240 people show up. This was a record. Just thank you to you. It's a model of, and when you say accelerate, I think you're accelerating. So our first point is, we really think we have to understand racism as violence and racism as structural. It's not about bad apples, one-offs. It's a system. It's the way the entire thing is built. And so, you know, we can have nice statements and we can have things embedded in our mission statements and so on. Those are important. But if we don't have the resources that go with it and that are properly supporting it, and if we don't change the structures, we're not really going to get anywhere. And I put up the picture of the report from the Missing and Murdered Indigenous Women and Girls report, because I think that is an example of going beyond individual perpetrators of racism and violence to look at how the structures operate and how structures need to be changed. The second point that we wanted to make is that when we're addressing instances, we refuse to ever have those instances being read as anything less than part of a big pattern. You know, seeing that every instance, from a microaggression to a very spectacular instance of violence against people, racism, or the consequences of racism, that we have to see it as the tip of the iceberg of the daily experiences that people are having in healthcare. And here I wanted to plagiarize the Sanyas iceberg, but Jane Collins put a note on that said that I wasn't allowed, so I didn't. But I think this is critical, that, you know, how many reports do we need? How many inquiries, how many inquests before we recognize that it's a pattern, and it's the pattern that needs to be changed. So this is kind of our was that the third point? Yes, I guess it was. That it's related, that we have to recognize that we have to go beyond the one-off responses are important, the inquiries are important, they draw attention, but they need to be seen as drawing attention to that bigger pattern, and they can't be dismissed until the pattern is eradicated. We have to look beyond that lure of, you know, Zizek says we're attention is drawn to the spectacular moments, and then that allows us to ignore what goes on every single day, and that's what we need to attend to. The fourth thing that we kind of wanted to say is that, and again, Elder Jerry, you just hit it exactly perfectly, that resources matter. You know, we got to talk about protecting wealth and protecting privilege, and you know, nursing is fraught with whiteness, and it's not about the who is in nursing, it's how we even do our practice. As a former emergency nurse, I used to talk to people like this. I used to say, okay, here's your gown, just take off your clothes and hop up on the stretcher and I'll be back in a minute. Now, who talks to people like that? That was normal. That's how I was taught to talk to people. And it wasn't until about maybe 15 years ago, I heard an elder, a residential school survivor, describing being on the receiving end of somebody speaking like that, that I totally understood. Well, I didn't totally understand, but I just got that, that my way of practice was so infused with harm. And that's what we need to change, is right at the right at the root causes. So as much as I'm an educator and I believe in education, we have to believe that, understand that the training that we've been doing just isn't sufficient. It's not enough. It's necessary, but not sufficient. And we have to push against that sort of pull to culturalism. Art is an example. Often when we're trying to do our intervention work and we're developing an action kit where we work with organizations to say, if you want to tackle Indigenous specific racism, here's where you start and here's what you need to do. But people are often drawn to the idea of Indigenous art. And it's, we can't just be slapping art up on a wall without developing relationships, without knowing who the first peoples of the land are, who we're serving. And this is a picture of the staff at St. Paul's did change the art, though try to make their waiting area much more welcome in their emergency, which it's great. And they did it in partnership, and they did it in building relationship, and they did it in friendship. So those are the kinds of things that I think we need to be going for. And our last point is that, and this is going to be obvious, that we have to have multi-tiered, multi-level initiatives that are throughout the entire system, not just aimed at individual providers, but really address the everyday ways people are experiencing healthcare. It's not about a bad security guard. It's about the idea that security guards are the answer to people's frustration with the inadequate care that they receive. I think that these kinds of responses just hide racism under the veil of choice or individual options. So Annette and I are here today to really take direction. We want to take direction from the Indigenous leadership that we're very proud to be able to work with. And we want to figure out how we can more boldly tackle the status quo, particularly in our case, really tackle whiteness, the whiteness of nursing. So those are just a few thoughts. And thank you once again for having me.
Thank you so much, Colleen. So it's Alicia here. I'm going to be moderating the chat today. I see you there, Leslie. Would you like to say something before we jump into the questions?
Sure. Thanks so much, Colleen, for your presentation and all of your support. I know that you and Dr. Annette Brown have done some real heavy lifting in this area and have been really strong allies and supporters to the work that we're doing, and particularly with contributions to research and to helping us develop the Sanyas Indigenous Culture Safety Program. I loved what you said about that constant pull towards culturalism. And I want to say, that's something that we always fight with, where people don't really want to know, they don't really want to know anti-racism. They want to know who we are as Indigenous people. And often as Indigenous people, we buy that concept thinking that, oh, if I just explain to everybody that, I come from a matrilineal society and I'm a member of the Killer Whale clan, then people are going to like me and respect me as a human being, when really I don't think it has any impact whatsoever. So thank you for pointing that out. I think that's a really important discussion point.
Well, Annette wanted to make really clear that we weren't in any way devaluing or dismissing the absolute importance of culture, tradition, ceremony. Of course not. But as you said, it's the structures underlying and how people are treated, and it can't get dismissed. Those issues, those problems can't get dismissed and covered up just because we've got a safe place for people to smudge. That doesn't solve the problem.
Okay, thank you, Leslie, for your question. Leslie, would you like to say anything else, or should I go ahead?
Go ahead, Alicia.
Okay, thanks. Okay, thanks, Colleen. So we have some questions here, but maybe we'll just start. I just want to ask you, you talked about the pattern of violence that occurs in the healthcare system, and we need to change it. I'm wondering if you could share any thoughts. I know we're going to be talking all about this today, but if you have any thoughts from your and Annette's experience in how to change that pattern of violence.
Yeah, I mean, we haven't, I have to say, we haven't had a ton of success really demonstrating massive change. But relationships, we've laid it out actually in a series of steps, knowing where your starting point is, knowing who the people are that you're serving. One of the emergencies that we worked with initially when we were touring through, the director was quite frank and said, I don't even know who the Indigenous people are in this area. And that's changed. So starting there, I think everybody needs to be involved. I mean, part of the problem with healthcare is we have such horrendous hierarchies that people who are providing direct care often have very, very little control or influence on how things are done or able to make changes. One of the emergencies we worked with, they just wanted to offer water to people. It can't happen. It just can't happen. No matter how hard the staff tried, they could not make it happen because of the layers of hierarchy. So we think that the first step is building relationships, building some momentum, getting to know who the local people are, but then starting to truly take a look at how things are operating. So we've designed all kinds of strategies for people to use. We've designed tools to rate your organization on racism, with, by the way, Cheryl's strong support on that. We've designed walkthroughs. So some of you on the call I know Elder Roberta, and she's actually been one of our biggest champions of doing these walkthroughs. So first of all, staff, you can walk through your setting and look at who would feel welcome here. How are people treated? How are people greeted? What are your intake procedures? What do they look like? Who's going to feel comfortable with that? How are people spoken to? And so on and so forth. And then walk through with somebody that can speak to who you want to serve better. So Elder Roberta will go arm in arm with you through your emergency department and have a look and talk about how it would feel to be here and how it would be to be spoken to in the way that we get spoken to. So we've got so many strategies, Alicia. We've got like 70 tools, and we have lots of ideas, and we're trying to figure out what is the most impactful. We do know that we need top-down leadership, but we also need frontline ownership. So we need to mobilize everybody and engage everyone. And I think that we've been told repeatedly to not focus on those that are stuck, but focus on the people that have open minds and open hearts and work with the 80% that really do see the necessity of change and want to achieve it.
Thank you so much, Colleen. And while you were talking, I just put a link to the equip tools, the toolkit that you're talking about, so people can take a look in the chat and they can find the equity walkthrough that you were speaking about. I have a few other questions that have come in here. There's a question on really wanting to hear more about your work on eradicating racism and dismantling white privilege, but in particular, could you share more about the successes that you've had, how you've had them when you've been confronting healthcare administrators or leaders in looking at, a diversity of ways beyond education and training?
Yeah, that is important. We think that every opportunity for education has to be coupled with action. And so you know, I think it probably is a slow process, but where we've had success is where we can foster, facilitate actual conversations among people that go across the silos and across the power hierarchies. And I'm going to give an example of one clinic that we've worked with that had real commitment to Indigenous people, real commitment to equity, to anti-racism, and yet they had such an entrenched hierarchy. And there were Indigenous staff, but the Indigenous staff weren't necessarily the physicians and the nurses. The Indigenous staff were the intake personnel, or they were, you know, there was an elder or a drug and alcohol counselor or whatever, and there was this big divide. And what they found was the most powerful thing was to have the conversations among each other and try to actually do something about that power hierarchy. So we've probably learned some of the most important lessons from medical office assistants, from people who are not necessarily positioned as leaders. And, you know, that a lot of times it's not that people don't have knowledge or they don't know, it's that they don't necessarily know how to take the next steps or how to move over and get out of the way. So those conversations seem to be really important. I think that creating safe spaces for everybody to participate is hard, and people with the most power have the most opportunity to walk away from the hard work. We've had less success engaging some sectors of the healthcare system than others, and it seems that the closer people are to the lives of those they serve, the more open they are to change. So I think that any way, without voyeurism, that we can really engage healthcare providers in understanding the lives of the people that they're serving and their histories, and the real impacts. You know, this guy Zizek that I keep quoting, or I think he might be quoting somebody else, but he says, an enemy is just a person whose story you haven't yet heard. So that might sound a little Pollyanna-ish, but I think it is about friendship and relationship and getting to know one another.
Thanks so much, Colleen. And so just speaking about conversations, when you were talking about the need for Indigenous staff in particular to come together around and have conversations, I'm going to be jumping and not doing these questions in order, but that's relevant to a question here that's asking about racial caucusing. And the question is about racial caucusing in general, and white racial caucusing, and what you think about this. Have you had any experience, or maybe we know that you have, can you talk a little bit more about working with healthcare staff in racially segregated groups, specifically for the purpose of talking about issues related to racism?
Mm-hmm. Mm-hmm. Yeah, we have had experience with that for sure. I think it's about building options, and I think it also depends on the level of safety and what we're talking about. And so, you know, one of the clinics that we worked with did have that. They had an Indigenous caucus, and I think it was important to those folks that they had that Indigenous caucus. I think that they needed an opportunity to build strength. But I had a very difficult thing happen in that I was assigned as a recorder for the Indigenous caucus in one of these sessions that we were trying to unseat things, and maybe stupidly I agreed when I was told that I should report on behalf of the group. And so I started reporting on behalf of the group, and the folks, the particularly one physician, and I don't think he'd mind me telling the story now, but when I reported back, he was very, very angry because I said that, you know, basically the physicians, the nurse practitioners took up all the airtime. They focused on the biology. They didn't focus on the lives of the people. And this was from the Indigenous caucus, who were mostly people who were, you know, social workers, counselors, like they weren't the medical providers. And the physician just yelled at me. He said, I don't need to hear this from you. I need to hear this from my colleagues. And this was exactly why they'd asked me to report, was because they were worried about provoking that. But then my lovely colleague kind of pushed herself in front of me and stood in front of me and said, yes, that's always been the way it's been. That's always the way it is. Like, she just said it really quietly. And it unleashed a whole conversation. And it meant that instead of them caucusing, they started talking to one another. So I think that, I mean, I'm not an expert in this at all, you know, in terms of what would work or wouldn't work, but I think it will really vary in terms of what is needed in that situation, in that context, and what the level of safety is for people. So maybe it's something that does have a position. And a second example is we, in our School of Nursing, we wanted to have conversations about racism. And so we invited people to sign up, not according to race or their identities, but according to their experiences. So we took the risk that people with white privilege would identify themselves as having experienced racism. We just took that risk. And we said, if you have experienced Indigenous specific racism, join group 6. If you've experienced racism on a daily basis or whatever, join group 5. If you've experienced white privilege, join group 2. And then people could join whatever group they wanted. And some people joined a number of groups, depending on their multiple experiences and identities. And that seemed to create quite a bit of safety for everybody. So those are just a few thoughts, Alicia.
Hey, thank you so much, Colleen. I had a question here, but I feel like, oh yes, no, it's here, great. So yes, we have some more questions about racism. So one question here just about microaggressions, picking up on the example that you shared. So someone is talking about how they can be so insidious, and there's often denial when microaggressions are challenged. And so the question is, how do we work with healthcare providers, including both students and practitioners, to identify and change the behavior associated with microaggressions?
Mm-hmm. Yeah, that's a question we've been really grappling with. How do you get those little tiny things that are hidden? They're so subtle, and they can't even be called out because they're not obvious, right? They're a look, a dismissal. You can't even put your finger on them. And I don't know if there's value in pointing to the microaggressions, or if there's more value in modeling what it should look like. So, you know, I try over and over again when, you know, nurses are often telling me, oh, you know, it just takes so much time. It takes less time or the same amount of time for me as a nurse to say, would you be comfortable getting undressed and putting on this gown? It takes the same amount of time. It doesn't take more time. So I guess I'm tending to try to focus on us all modeling more respectful, appropriate behavior. So I think that maybe some of our other speakers will have a better sense of how we can call out and point to these microaggressions, particularly the eye rolling and the dismissal and the back turning, all those subtleties that are used on a daily basis.
Thank you, Colleen.
Thank
Hi,
you,
Nancy.
Colleen. I hope it's okay, Alicia, if I just make a comment. I have such a struggle with the term microaggression, because as an Indigenous person experiencing it, it doesn't feel micro at all. Um, and there's kind of this tendency in healthcare to minimize, like starting off with things like unconscious bias and addressing microaggressions. But sometimes I feel like we should just call it anti-Indigenous racism or Indigenous specific racism, because a million, like Jerry says, a million little cuts, it still impacts Indigenous people as violence. So like I just like to trouble that term a bit.
Mhm.
Thank you. I had.
Excellent. Yeah, I actually agree with you, Nancy. I don't know how that it's crept in, and that the terminology has crept into a lot of the conversation, and you don't necessarily think about what's the impact of that micro, uh, making it smaller, more containable. Yeah, maybe we should just ditch that and just call it aggression and violence. Yeah. Mhm.
Thanks, Colleen. Thanks, Nancy, for your excellent question. I actually have another question that was submitted by an anonymous attendee that is speaking about, uh, I guess, more well, about racism and maybe more macro aggressions. So this person has spent a long time working in cultural safety and humility training in a local context, and shares their knowledge with a classroom full of settlers, and has been confronted violently by white fragility that extended to leadership. And so this white fragility actually threatened this person's place of employment, and they're wondering what can they do to help Indigenous people navigate white privilege and white fragility. Um, in particular, how can we better assist Indigenous people um, to recognize, to navigate, recognize white privilege, white fragility, to keep themselves safe and to speak out against it. So, you may, I don't know if you want to say a few words about white privilege and white fragility, and if you have any thoughts around navigating white fragility, particularly for Indigenous people in workplace contexts.
That's a pretty big set of questions. Yeah, I mean, I think we have to start talking about white privilege. We disappointingly, some anonymous person in our school of nursing thought that when we talked about, you know, white superiority and white privilege, that we were talking about the Ku Klux Klan. I can't say that. KKK. That's what we were talking about. That they didn't recognize how that our entire society and healthcare system is structured on whiteness. They didn't recognize that. So I think that we need to make that part. This is, we keep focusing on Indigenous people. And whose business is it to dismantle white privilege? Who needs to get out of the way? Who needs to move over? So, I mean, I think there's a lot of work to be done, and I don't think in this short, I don't think I know the answers to that complex question, but I think that we're going to hear a lot more about it throughout the day.
Thanks, Colleen. And I appreciate you mentioning the KKK. I just noticed, and I'm watching the chat and moderating at the same time, that someone has linked microaggressions to white supremacy. So I think we'll be talking more about white supremacy later on today. So we have another question, and this is going back to your research. And I know that you've talked a little bit about the tools, and I don't know, as if part of this conversation you want to speak a little bit more about EQUIP and the tools that you've developed. But this question is actually about the separation of healthcare from community-based services, and the wondering about if your research has addressed any of the breaking down of silos that happens between sectors, and how this has impacted relationships, and how breaking down silos can lead to new relationships and challenging hierarchies. So maybe if you have
Mhm.
any comments around um, working across sectors and building relationships, and how that can disrupt some of the power structures that may be contributing to racism.
Mhm. Yeah, I mean, we have a hierarchy even within the healthcare system, eh? And if you follow the money, where's the money all go? I used to work at open heart surgery, and that's where a lot of the money was, and uh, further and further away from the community, shoring up a system of privilege and a focus on biomedicine. And as I said, I've observed that as nurses, the closer we are to people's lives, if we're working in the community, you can't deny the realities that people are facing on a daily basis. But if you're working in an intensive care unit, you can ignore those realities. And so, I think that whoever made the comment is completely correct. That breaking down those silos and having more emphasis on the community. I think that the entwined crises of the opioid overdose crisis and COVID have laid bare all of these inequities that were always ever present, but they've also shown us how absolutely crucial the public health, the community health is, as opposed to just focusing on acute care and stuffing more and more resources in there. So I think that at the level of budget, at the level of resourcing, and then at the level of being able to talk across silos with one another and even work together. The reason we even tried to work with emergency units is we were working in primary care with partners in primary care, and they kept saying, we can provide pretty good care in our clinic, but as soon as people hit the emergency, everything falls apart, because there's a wall between the community and the rest of the healthcare system. So yeah, really good direction.
Thank you, Colleen. We have another question that's come in. I know we have about nine more minutes left here. So if folks want to ask other questions, now is your chance. You can put them into the Q&A. So someone has a question here about land. They're making the link between reaching this place of wholeness, restoration, reconciliation, and ultimately eradicating anti-Indigenous racism, and suggesting that this is really only going to happen when the governance of the land goes back to Indigenous peoples. And this person is asking, is this part of your work at all, or the dialogue in your work? How does the work that you're doing around equity and anti-racism relate to the land or efforts to give land back?
Mm-hmm. That's part of that bigger conversation about I think that's what we were saying is the protection of privilege and wealth has to be part of the conversation, whether it's supporting land claims or whether it's talking about who gets to make the decisions about how healthcare resources are allocated, how people are compensated, who is compensated properly. We've made little tiny inroads in having actually elders paid properly, but is there an elder on a pension plan? So from the full scale, from the smaller decisions up to those bigger land claim decisions and resource decisions, I think that has to be part of the conversation for sure. Do we specifically address that when we're focused on healthcare? I think we're trying to deepen. I worry that sometimes the land acknowledgements have just gotten rote in some settings. I don't mean that any of us are doing that, but what does it really mean when I show a picture of Skowlitz? I'm sitting on Skowlitz Reserve, Lot P. That's where I am. What does that really mean? And what does that mean for my politics? And what do I have to do in terms of my commitment for that? And what can I do within healthcare? How can I, there's so much to be done around land-based work, land-based healing, reclaiming land and restoring land, that we can all support. Yeah, I think much to be said.
Thank you so much, Colleen. So we have a few more questions here, and I have one for that's come in for you, Leslie. Maybe I'll just ask it right now, and you can think about it maybe for some comments later. So the question is around how do we about white fragility and white privilege and white supremacy. How do we get those words into the public lexicon? How do we start talking about those concepts? Considering we land acknowledgements are so prevalent, how do we get the conversation around white fragility and white supremacy, that language becoming so prevalent as well? So I'm just going to leave that question with you for now and go back to Colleen, and maybe you'll want to pick it up at some point later. So Colleen, there's a couple of questions in here. There's one around barriers to systems change. So someone's saying that every time they go to change systems, they encounter these barriers, and this person is still learning. They're a beginner and they want some advice. So what is your advice when running into what this person says is, politically correct processes like consensus, or when everyone gets a vote on something, and often this tends to delay the disruption of racism and the status quo continues. So do you have any advice for beginners who are running into these barriers at a structural level?
Mm-hmm. I guess the tackling it at all levels, having allies. I don't know if it's truly good news, but we have had absolutely nothing but 100% support at executive levels for the work that we're trying to do. Now, does that actually translate into change? I don't know, but at least we've got the support. So I think that if somebody is particularly direct care providers trying to make their concerns and their voices heard, and connecting at other levels, I think that leadership within, I'm thinking of health authorities, leadership within health authorities does really attend to front care or frontline or whatever you want, that's military language, but direct care providers actually raising concerns and bringing concerns forward. And I think it does take bravery, but Leslie opened with that story about her and Cheryl thinking that they were gonna get fired. And I think that we have to take risks. We have to go out on a limb, all of us, to make change. So I think everybody has to keep speaking up, and we can hear that people are speaking up. We just have to be really careful that the speaking up doesn't become rote and meaningless, and actually giving the impression that something's being done when it's just surface. So I actually wondered, Leslie, did you want to jump in with your thoughts around white fragility and white privilege and how we can get that language? I mean, I think you've given us permission to stop with just the cultural safety and really name anti-racist and anti-specific, Indigenous specific racism. What would you say though, Leslie?
Well, in the same way that Cheryl and I put our roles at risk to develop the SANYAS training program in anti-Indigenous racism, I would say that this is a piece of work for our allies to take on. If we were, whenever Indigenous people are talking about white supremacy, we get a lot of pushback. We put our roles at risk. I'm thinking of every single person working right now in a health authority. When you're sitting there at your senior leadership tables and talking about this, it's a really tough, first of all, it's a very, very heavy emotional burden for any Indigenous person to wear. And I always wonder, why am I the only person speaking to this? And why is this burden my burden? And why isn't it your burden? So I really think this is a strong issue that our non-Indigenous folks here need to know and understand about, and they need to be leading the pushback on it. And when you were talking about when we're seeing racism and calling out racism, or maybe I was reading it in the chat, they need to be calling out racism. It's safe for them. It's not safe for us to be calling out racism and to be using those kinds of terms. That's my thinking, Colleen.
Thank you so much, Leslie. And I see there's that you've commented in the chat too, and there's some more dialogue about it, which is great. So we just have 1 minute, so maybe I'll just throw out, combine this last question and leave you with a minute to share any final thoughts, Colleen. So I guess there's a couple questions here and there around policy and practice or praxis. And so, do you have any advice or suggestions on healthcare settings, on hospitals, organizations who are trying to make change? What could they do in relation to shifting their practice? And what could be done to address some of the policy issues, particularly when trying to make long-term change? So I'll leave that with you to share your final thoughts, and then after you're finished, we can turn it over to Leslie.
I don't know why people ask such tiny little questions. They're so huge, and I think this is just the nature of our work. Is the questions are so huge because the challenge is great, and we have to not get overwhelmed by the size of the challenge, and everybody do their part. And I saw something flash by about in the chat about unceded, and I think that's one thing we could start is, what does that even mean? I mean, we say unceded, but what does it mean that land is unceded? So yeah, I mean, we have to be tackling at all levels, and it doesn't matter where we are in the system, we can be doing be doing our part. And I think that looking at everything as a structural issue, looking upstream at the causes, is what I would just say as a general thing. If you see a problem, like looking at the context, looking at, you use the word, or somebody used the word praxis. Praxis, according to Freire, is reflecting in and on the world with the intention of change. It's not just like doing things in the same old way. It's reflecting on the world and how it's structured. So that would be my parting shot. So thank you for having me, Alicia and Leslie.
Thank you so much, Colleen. And thank you everyone for including your questions in the Q&A and in the chat. I know there's lots of great conversation going on, and that really helps today become a richer dialogue, which is the intention. So thank you to everyone, and I'm going to turn it over now to Leslie to introduce the next speaker.